ENT surgeon and laryngologist from Derbyshire Royal Infirmary, United Kingdom. An alumnus of Caltech Medical College, he has underwent training for the surgery from UK and Netherlands. He is a regular invitee to national and international conferences on laryngology and oral surgery. He has also conducted several instruction courses in Australia and Belgium. Currently, Dr. Sharad is a member of the Council of Directors of British Voice Association. It is indeed a privilege to have him amongst us, and we welcome him to this session. And this session will be chaired by Dr. Patmanathan, Senior Consultant ENT Surgeon, Pioneer, and Dr. Vandana, Principal of AWH College, Calcutta. I invite the chairpersons to rise. Over to the chairperson.
Thank you very much for inviting me here. I'm very pleased to be here. Though it's a bit frightening for me because this room was a biochemistry lecture and I had failed twice in biochemistry, so it gives me the shivers to come back. I'm very happy to come to Calicut. I've not come to Calicut before in the medical school, such an audience. I'm very happy to be here. There's a slight problem with my computer with some videos, but I think we'll sort it out soon. We all heard a lot about surgery. Jacob, you were able to talk about surgical techniques and laryngeal framework surgery, microflap techniques, and etc. But as a surgeon, my advice to you is a surgeon should know when to operate and when not to operate, and how to select patients. So this talk is mainly on assessment, taking the history and come to a diagnosis, and then decide whether to operate or not to operate, and if operating, which surgery to do. Sorry, I have to use the case computer because my computer is not working here. I've been doing voice surgery, running the voice clinic in Derbyshire Royal Infirmary for the last 12 years now. And ideally, we'll talk about the voice team, what it entails, what kind of equipment you need, and how to take the history, how to diagnose, etc. This is my voice team. This is a surgical team, and this is the clinic team. Kate is actually in both teams. Kate actually is a speech pathologist who works with me in the last 10 years. She's especially imported from Melbourne, Australia. Kate's actually also the surgical team because she comes to the theatre to scope the patient while I'm doing a diaplasty to look at the visualization. Also to check the voice on the table. When the patient is lying flat for an hour and a half and dry and difficult position, we won't be able to assess the voice properly. So they have some techniques to do that. This is our equipment. We have two. It's part of a digital archiving system with playback facility. So every patient is videotaped so that we can play it back and have a look at it. And we have a camera, not a light stroboscope. The advantage of camera stroboscope is that the camera flickers so that the light quality remains the same. And we also have an air pulse sensory stimulator, which is to assess the integrity of the superior laryngeal nerve. So we can actually deliver air pulse to that mucosa, and that will elicit a laryngeal adductor reflex. It's a protective airway reflex, which is very useful for endoscopic evaluation of swallowing. These are some of the scopes which I use. As you know, this is a flexible 3.6 millimeter diameter flexible nasolaryngoscope, the nasolaryngoscope, and this is a rigid scope. This scope this is a 70-degree scope. That means the lens looks at 70-degree angle, and you can do 90-degree scope as well. This is a head-on camera, so you can add the camera head to either flexible or rigid, and you can attach stroboscope to both of them. We do flexible and rigid for both for each patient, Because flexible is useful to look at the function of the larynx. The patient can sing, count, etc. Whereas rigid is useful for looking at lesions, because patient can't provide much with the tongue, mouth open and tongue protruding out. This is a transnasal esophagoscope. Again, 3.6 mm diameter. You can actually do transnasal esophagoscopy into the stomach. Every patient is given a questionnaire and the patient self-rates. For example, there's something called voice handicap index. So you may be a singer, you may have a slight voice problem, which is a big handicap for you. You may not be a singer, and you have a big problem, but you're okay, you're not. So how much the patient feels, how much of a problem the patient feels as a handicap. So that's it, you have to take that into consideration. I'm sure you're familiar with reflex. It's a fairly new entity, people are getting more and more aware of it. It's the laryngopharyngeal reflex disease, which is different to gastroesophageal reflex disease, which is symptom. Because laryngopharyngeal reflex disease, the symptoms are mainly hoarseness and throat clearing and cough, and not heartburn. So most of these people end up in your clinic. Occupation is very important, especially teachers. I always ask them what kind of class you are teaching. So for example, that is actually straining my vocal tract and the vocal cords. So occupation is important. Personal habits, how much they drink, how much they smoke. So those things are important. Vocal abuse. This man, probably you are familiar with this face, amazes me because he's been abusing his voice for the last 20 or 30 years and still got a very strong voice. So I don't know. I have not seen his larynx, so it's interesting to look at his larynx. He sends his apologies in England for having a holiday, paid holiday. This is actually, you know this man? Alex Ferguson, he's the coach of the Manchester United football club. He's actually shouting to the players against the background noise. So, if you're in a restaurant or in a crowded place, you think that you're not talking loud, but automatically your loudness goes up. And then if you do it on a regular basis, like these girls are doing, you get into trouble. Previous illnesses, surgery, neck, facial surgery, neck surgery, chest surgery, there is a chance that a nerve can be damaged, especially superior laryngeal nerve, which not many people take into consideration. And if you can use subtle voice change, patient will be monotonous. Patient will be able to raise the pitch that much. There's something called laryngitis. You get a sore throat, you got a viral infection, you feel like flu, having a flu. You get laryngitis, your voice becomes hoarse, and you go to your doctor. In England, actually, they go to the GP. I'm sure in this country, probably they come to you as an ENT. But in England, they all go to the GP, and GPs don't have ability to actually see the larynx. So they call it laryngitis and put them on antibiotics. And some get better, some don't. There was a study in America where they actually scoped all these so-called acute laryngitis patients, and they found there was paresis of the vocal cord. They call it the Bell's palsy of the larynx. The Bell's palsy is very obvious because it's on your face. If you have weakness on your face, you can see it straight away, you diagnose it straight away. Bell's palsy of the larynx is not diagnosed. They call it laryngitis, and some don't recover from it. So they end up having it coming to your voice clinic. Hydration. You can see I'm drinking water here, and not tea. Water doesn't include tea, coffee, or alcohol, which is got the opposite effect. So how much of water you drink is very important. Because when you run, your throat becomes dry. Throat is one of the earliest organs which get dry quickly. And you need good hydration for you to get a good mucosal layer. And how much of water you need to drink in a day? Is there any measurement? It varies from country to country. What I tell them is, drink until your urine is clear. If your urine is yellow, that means you're not drinking enough water, unless you're on some medication. So hydration is very important. Medications. Are they taking inhalers? And if so, are they using correctly? Are they using a spacer device? Inhalers can actually deposit on the local cord because it cause inhaler-induced laryngitis. There are new inhalers which gets activated only on contact with lung tissue and not with laryngeal tissue. So some of the patients I prescribe that for them if they got asthma. Antihistaminics dries your vocal cords, your larynx. Posture. It's a bad posture. A good one. I don't know about this posture. The posture is important. For example, if you look at me carefully, I don't think I can demonstrate. Maybe I do it in Bangalore when I go there. My larynx is actually to one side. My Adam's apple is actually to one side. That's because I have a problem with my ankle. I had an accident about 12 years ago. So my posture is different, and that has an effect on the larynx. So, like Dr.Murali said, it's a whole body, and the movement of the larynx actually to one side can cause problems. That's why I can't sing very well. Always make sure they have good lung reserve before you actually operate on them. The lung is power source, it's the most important source. Whereas larynx is vocal cords are vibratory source. You can't speak without vocal cords because, as you know, after laryngectomy, still you can vibrate the T segment to produce voice, produce sound, and vocal tract. But lungs is the most important thing. Again, Dr. mentioned today about hormonal changes. This lady is a soprano, she sings on very high pitch, and she notices that her voice changes just before her menstruation. She tells that, oh, I know that my periods are going to come, because my voice is different. So again, I don't advise them to sing during that time because chances of hemorrhage is more. So pre-menstrual and 1 or 2 days during the menstruation, I don't advise female singers to sing in high pitch. Nobody will present to you like this. I am stressed. This is just a picture. And there are several emotional, stressful issues which you will not pick up as a doctor. But that's you have to take that into consideration. Most of our patients get speech therapy, and then speech therapists are also trained counselor can spend more time with them, and then they come out with their emotional problems. So that's emotion. That's why when you're upset, your voice changes straight away. So voice and emotion very important. Yeah, some of the voices will become psychologists. We don't have it, but that's a very important part of the team. So summarizing the whole thing, these are the things which you have to take into history. It will take a lot of time. That's why we give them a sheet to fill up before they come to the clinic. Again, this is a Kaufman's reflex symptom index. So as you see here, laryngopharyngeal reflex disease, heartburn is the least common symptom, but this is the most common symptom. And then if they get a score of 10, more than 10, it's suggestive of laryngopharyngeal reflex disease. We treat them with high dose PPI and antacid solutions. And this is a voice handicap index. Patient feels that there's a scoring as well. And I'll try to show a video. I hope it works. It didn't work this morning. This technique of flexible nasolaryngoscopic examination. I don't use any local anesthesia at all for this procedure. I just use some gel, KY gel, to lubricate the scope. And patient should be sitting up, and the doctor is slightly higher level than the patient. And you watch the monitor. Okay. And then when you reach the nasal pharynx, ask the patient to hum, like the pharynx goes up, you can get it like easily. This is a very useful technique to look at the function of the larynx. Muscle tension disorders, this is very useful. Can you hear the back earlier? Yeah, like I said, flexible basic endoscope shows all these things, and they actually it's all techniques, speech therapists use to look at the movement of the larynx, and I'm sure Kate will talk about it later on. This video I will show you later. Rigid scope. I'm going to show you the technique of rigid is video laryngoscopy. And there's an equipment here, stars has got something here. Probably there's a patient or a person who can demonstrate the technique of stroboscopy. The patient sits up with chin forward. That's an early morning sleeping position, the original position. Like when you use the indirect laryngoscopy, we are at the same position. And the tongue goes forward, tongue out, like that. And either the patient holds the tongue, or you can hold the tongue with your left hand, or your non-dominant hand. And you ask the patient to say E. E means tongue is going forward. We have actually spaced at the back of the tongue for your 70-degree or 90-degree telescope to look at the larynx. And the patient has to breathe through the nose or mouth. Mouth. Because I'll show you what happens when the patient breathes through the nose. So if you want, you can actually put something in the nose. This is the technique. Patient is now breathing through the mouth. Wide open mouth, tongue forward. Camera sits nicely on it. For this I use a local anesthetic. I use 4% xylocaine spray. Now the patient is breathing through the nose. What happens? Tongue goes up and the palate comes down and you lose the picture. So technique is very important. You can do this even on children if you prepare the patient properly. Stroboscopy is not new. This gentleman actually tried stroboscope in 1895. This is a spinning wheel. And so he used a mirror to actually rotate the wheel, and the light comes to the tools. And so it's not something new. Sorry, my message. Right. Okay, I want you to say E for That's roughly about 200 hertz. Means Kate's vocal cords are vibrating 200 times per second. And I'm going to do a nice manly that's about 80 hertz, which means that my vocal folds are vibrating 80 times per second. And there's no way you can see it. Do you want to see it, or is there a point to see it? Or yes or no? Yes. What stroboscope does is emitting stroboscopic light at a frequency slightly off your pitch. For example, with 200 hertz per second, it might emit light at 170 times per second. So instead of falling on the same spot like this, in which case you get a straight picture, it falls on different parts of your vibratory cycle. So you get an illusion, it's not an illusion. You get a slow motion picture of several waves seen as one wave. It's not real. Only way you can see the real movement is video chemography, which is still in the research stage. Prakash, are you using chemography? No. So that's still research stage, but if you want, I can show some clips. It's a high-speed camera, which takes about 4,000 pictures per second, and slow it down, then you can see each individual wave. We talked about the mucosal wave theory. You have the Hirano's body cover theory. The body, the squamous epithelium, ring-case space, elastic fibers, collagen, and muscles, the layers of the vocal cord. And this is purely diagrammatic. The collagen content can vary from patient to patient, race to race. For example, Afro-Caribbean people, African people has got high collagen content. As for they sound different. You can tell, oh, it's an African man talking. They got this high collagen content. It varies. So what happens? This is the body. This is our slides of the body. That happens 200 times per second in Kate's case and 80 times per second in my case. So you'll see the supple movement. So you see, if you have a lesion over here, you don't need stroboscope. You don't need stroboscope, you can actually see it with any mirror or light or whatever. If you have a lesion here, here, then you won't see it with your mirror. Patient will still be hoarse. Then stroboscope will show that there is some stiffness there. Then you say, okay, there's something there going on. So I have to target my biopsy there. So you might even diagnose an early cancer. So that's one of the clinical importance of having a stroboscope. I'll show the technique one more time. Again, in this video, I think you can see the patient's position. A generous amount of local anesthesia sprayed at the back of the throat, the base of the tongue, because not many people can suppress the gag reflex. And then the patient sits up, straight from the hips, chin up, breathing through the mouth, tongue forward, and say ee. But they sound like because you're holding in the tongue. And you place the camera 70 degrees or 90 degrees, and you have a. What happens here? I'm focusing it. You can see the picture nicely, and suddenly, as soon as I start the strobing, the picture disappears because it's too much light there. So the picture disappears, but then the nurse. Sorry. So then adjust the light and then you get a picture. You can see the stroboscopic vibrations. Nice and healthy, relaxed larynx. In a healthy larynx, you should be able to see the whole length of the vocal cords all the time. Usually singers have very nice and relaxed larynx. If you can't see the whole larynx, whole vocal cord, length of vocal cord, that means there's some muscle tension. And that can cause problems. So what are you looking for in stroboscope? You look at the vocal fold edges, you look at the closure, you look at the symmetry, you can actually look at the vertical level, is there a difference in level between the vocal cords, the amplitude of the mucosal wave, and how is periodic or not. These things we are looking for. This video I'll show you later. So these are some of the clinical applications of video stroboscopy which I mentioned before. Then we discuss the results with the patient. We show the take back to the patient and discuss a management plan, which could be speech therapy, surgery, medications, or a combination of all, and this is some of the investigations depending on the patient's condition. Audiometry is important. Why is audiometry important? Why? Because you need the feedback of your own. You have to hear your own voice for you to modulate your volume. For example, if you must have seen when you travel in the train, some people put headphones and listen to music, and if you talk to them, they'll talk very loud to you because they want to listen to their own voice because they hear the music. They want to modulate, they want to increase the volume. So that feedback is important. So some patients with hearing loss, especially sensory neural hearing loss, audiometry is important. That's why people with otosclerosis are very soft-spoken because they hear their own voice louder. I'm not going to talk about this case, I'm going to talk about goals of voice therapy. Vocal hygiene, very important. So, avoid irritants, avoid smoky places, throat clearing. Is it a good thing or bad thing? I don't think many people are clearing the throat now. Last time when I came to Pune, a lot of people are clearing the throat. And as soon as I said that, I stopped it. Throat clearing as a habit. It becomes a habit after some time. It's not good. Hydration, ventilation, and limit your. A good singer will not talk too much. They preserve their voice for the performance. So if you're a singer and then you talk as well all the time, then you get into trouble. I'm not going to talk about Jacob has already mentioned that. So what can you achieve? I'll show you some good results, okay? To make you feel happy, make me feel happy as well. One of my presentations recently was showing my bad results. Not many people show their bad results. So I'm going to show some good results first. If you want, I can show some bad results tomorrow. Okay, can you start? Thanks for the left palsy due to lung cancer. And actually, what's the problem of the voice? It's very breathy. Air is leaking through. It's very breathy. And this is the maximum phonation time, which is about maybe 5 or 6 seconds. A normal maximum phonation time is about 20 seconds minimum. And this is what we achieved after theraplasty.
1, 2, 3, 4, 5.
Right, okay. Play, please.
1, 2, 3, 4, 5.
So that had a lot of closure and then this maximum phonation time is increased quite a lot. So you don't get such results all the time. So see, this is one of the good results. So you can achieve such results, but not all the time you get it. It depends on various factors. So this is as Dr.Murali mentioned, this is the second most common theraplasty technique in the Western world, androphonia, or in my practice we get male to female transsexual. They have sex state and then they want to change. They do other jobs first. They do the jobs, boob job, and then they come to you with the voice. So what you do is to mimic the action of the tricothyroid muscle. What does tricothyroid do? It brings the thyroid and tricot together and thereby stretches the vocal cord, the pitch goes up. I'll show you an audio clip because this lady didn't want to show her face. This is a lady.
It's 20th of the 10th, 05. When the sunlight strikes, raindrops in the air, they act like prisms.
This is a lady, 39-year-old lady who had 3 children. And each time she got pregnant, her voice dropped and dropped and dropped. So it sounds like that. Can you play that again?
Lorraine Stevens, 20th of the 10th, 05. When the sunlight strikes, raindrops in the air, they act like prison.
She's an antidepressant, you can imagine, because somebody rings her home and she picks the phone up. She's actually Mrs. Stevens, and people say, oh, Mr. Stevens. So she's, and then what we have achieved is like that approximation.
Lorraine Stevens, the 9th, the 3rd, 06.
Not a
When the sunlight strikes, raindrops in the air, they act like a prisoner on former rain.
But I'm very glad that Calicut Medical College started the voice lab today. Be careful. I've been doing this for 12 years. You get caught out sometimes, so don't jump into surgery all the time. Learn to stand first before you start to run. So even if, like Jayamona said, even if you spend some money, get the best instruments. And I'm quite particular about good theatre comfort. I won't rest my hands, elbow or something, especially when I'm using the laser beam. But again, sometimes it all costs money. But stick with the principles, whatever instruments and the setup you have, stick with the principles, use the right tools, and talk to people, talk to the right people. You've got a lot of people, I would say, one of the best laryngologists in the country, compared with anybody in the world, I would say. So talk to people like Padil Kumar or Jai Kumar, if you have any doubt. So the more you do, the better results you get, and more problems you have as well. So I wish you good luck with your. Thank you very much. Before I stop, can I go back to the video?
Do we have time for questions, sir?
We now move over to live demonstration of strong spoken.
I just want to show one short video clip. Something which is very interesting. I want you to diagnose this. Just watch the larynx carefully. This patient was referred as called laryngeal pathology by a ENT surgeon to our clinic. It's too dark. Can you see anything? And now can you see that? Stop it. Can you see something? Something there? Wait. Can you see something there? Oh, what is it? Okay, yeah. Shiny. Where is the product? Subglottis. See what happens now. So watch carefully and see what happens now. I'm asking the patient to clear the throat. Okay? We clear the throat, but follicle is still there. Still there. And that's a big cough, and the follicles just come out. Yeah. It's only mucus. Only thick mucus. So ask the patient to clear the throat and cough. All these things are important before you diagnose something which you think is the problem. Okay, thank you very much.
Thank you, Dr. Sharad. I think that's more appropriate. Thank you, Mr. Sharad, for your good view.
We now move over to live demonstration of stroboscopy on selected patients, which will be chaired by two very eminent dignitaries who are very special to us. We invite Dr. Ashok Kumar, former head of the Department of ENT, Medical College, Calicut, and Dr. Muhammad Iqbal, Senior Consultant ENT Surgeon from Palakkad.
We now another session, and I have a demonstration that is simply on mathematician by Dr. Samet, on the slide, and Dr. Jay Kumar.
Second 50-year-old lady.
This 50-year-old Anganwadi worker presented the changing voice of 2 months duration. It was started and answered follow the changes of enunciation.
Yeah. 2 months.
So you can watch the position self is asking the patient to sit in. Sit comfortably, relaxed. Shoulder has to come anteriorly and the chin has to be up. So she is a concentration voice user teacher and listen to her voice is very hoarse and low pitched and MPD is very poor, just 4 seconds, 5 seconds. I think you all could see that, but there is a lot of mucus also. So you want to ask them to come out and then do. Then there is a lot of mucus, and you want to do first. If whichever is your comfortable position. ഇരിക്കണം. You can see that the whole right vocal cord is actually very congested when compared to the left vocal cord, and there is a polypoidal mass somewhere at the junction of the anterior and maybe a little bit posterior, and lot of mucus from the mucosal waves maybe diminished on that side. So there is monotone also here. There's got an acute monotone also. There's a lot of congestion of medial margin of the vocal cord. The vocal cord polyp there. It's not a nodule, it's not a bilateral condition, a unilateral condition. So probably resulted from a severe acute voice insult, maybe a bleeding, submucosal bleeding, which probably got organized.
Yeah, I agree with you, Jacob. It's a traumatic hemorrhage to the vocal cord, formed a single cyst. We see a lot of these patients in football fans. They go and shout and scream, and next day they come with this problem. How do you? So 2 months. Yeah, 2 months since she has not. What we would have, I would have done normally. I don't know the gentleman. I would ask them to do some voice rest, relative voice rest. Start with not now when she came first, and then probably put them on some steroids, vocal hygiene water, and then come back and see them. Sometimes they disappear, sometimes they don't. And in this case, I think she needs surgery.
Even now, probably it is because it is still very fresh. So there is still probably a lot of voices, and we can wait. There is no harm in waiting, say 1 or 2 weeks. Because it still so red on the right vocal cord. It's probably not ideal time to overreach.
Yeah. You want to?
Yes, I think I will find out if though I can't at the moment in my lack of manual how much you're using your voice volume. My volume's not that good. And just steam. Steam is very good for circulation and in healing congestion. Boil the kettle, put it in a bowl, no inhalants, add it to the water. 5 minutes, a few times a day. Drink plenty of water. Just things that help with circulation. Lower the speaking volume, reduce the quantity of speaking, and that should look less red when you look at it again.
Doctor until now, then so you probably would wait for a few weeks.
I think that is better. Probably if he can wait, probably that is better. Because it's still very red, that is the problem. You can see the striking contrast between the right cord and the left cord color. It's so red. I think you give little more time to work and we will get the result. And in the meantime, the speech pathologist also can start the pre-operative voice therapy. So why this happened, how it can be avoided, she can reach the vocal hygiene, everything.
Yeah, I agree. So the chance of hemorrhage at the time of operation and more scar formation probably is more in this case. Yeah.
Some speech therapists think that very, very gentle exercises can help with circulation of vocal folds, but that's a bit of a muted voice at the moment. I don't think everyone agrees with you in this condition.
Year-old man was presented with painted loss of 6 years duration. It was insidious in onset and gradually progressive. He gets temporary improvement with voice rest. There is no history of voice abuse or misuse.
6 years.
6 years duration of insidious in onset, gradually progressive, and he gets temporary relief with voice rest.
How old is he?
34 years. Andrew Haber.
തരത്തിലുള്ള തോന്നുന്നില്ല. some ഭക്ഷണമൊക്കെ സംസാരിക്കാൻ പറ്റുന്നുണ്ടാവും. കുറേ ശബ്ദം തളർന്നു vocal fatigue response.
ഈ നിർത്താതെ പറയും, ഈ പറയും, ഈ നിർത്താതെ പറയും, ഈ കണ്ടിന്യൂസ്, So the striking finger touch, you notice there is a phonetic. In no state during that cycle of phonation, there is complete closure. And if you look carefully, the amplitude of the mucosal layer is confined only to the medial margin of medial one there. Normally it should be at least 50% of the superior surface. The mucosal layer should go reach almost up to the ventricle. So here it is confined to the medial one there. So commonest cause is a sulcus, and that is why I was asking the history. Even listening to his voice, you make such vocal bending is very common in sulcus vocals.
Fortunately, sulcus vocal is not very common in our
Fortunately.
I don't know experience. I have probably seen only 10 patients or something. And most of the patients I've seen in the UK are from Asian origin.
Yes.
So it's probably from genetic.
Very high.
And there's something called pseudosulcus. What's the difference between pseudosulcus and true sulcus? Sorry? Beyond the vocal process. So pseudosulcus is a feature of laryngopharyngeal reflex and not sulcus. The sulcus, a true sulcus will stop at the vocal process.
So can we see that once again? Stand here. Here once again.
Concentrate on the medial most margin and concentrate on the mucosal layer. It's actually confined to the medial one there, the mucosal layer. Mucosal layer is only for the medial one there.
This 45-year-old salesman with history of voice abuse presented with hoarseness of 3 years duration. The symptoms are worse towards the end of the day with complete loss of voice occasionally.
He is a businessman, a lot of voice abuse. He has got a recent onset voice problem, and it is worse in the evening. maximum എത്ര സെക്കൻഡ് നമുക്ക് തുടർച്ചയായിട്ട് ഒരു ശ്വാസത്തിൽ സസ്റ്റെയിൻ ചെയ്യാൻ പറ്റുന്നതായ But I say that by Indian standard FPV is not as high as 20. It is generally 10 to 15 millimeters. ഈ ലെസിന്റെ വ്യൂടെ വേറെ അസുഖങ്ങളൊന്നുമില്ല, സ്ഥിരമായിട്ട് മരുന്ന് കഴിക്കുന്നൊന്നുമില്ല, ആസ്പിരിൻ കഴിക്കുന്നു, എല്ലാവരും കഴിക്കുന്നുണ്ട്, ടാബ്ലറ്റ് കഴിക്കുന്നു, ഒന്നുമില്ല. എല്ലാം വേറെയാണ്. ആസ്പിരിൻ നെഞ്ചെടുത്തില്ല, ഗ്യാസിന് ചെറിയ പ്രോബ്ലം എന്ന് പറയും. അപ്പൊ എന്ത് ടാബ്ലറ്റ് കഴിക്കണമെന്ന് പറയും. സ്മോക്കർ aspirin is a very important history in medical history in most of the boys because they are more prone to develop the monotone and the medial margin, especially the undersurface, the inferior lip of the vocal cord will have, most of them will have small hemorrhagic cells. ഒന്ന് ചുമയ്ക്കണം. So you can see a big reddish polygonal nodule on the left side, but there's a small, very small nodule on the right side also. You will go for surgery for him? Yeah, this is unlikely to resolve by this voice therapy.
And could you, in the audience, obviously he needs removal of the collar on the left vocal cord. From the right cord there is a contact link. Would you do anything for that? No? Yes? No? No? I won't.
It is too small. Then it is likely to resolve by itself.
Yeah. Yeah. So mainly resolve.
This is likely to resolve. The small thing is likely to resolve by itself. In this case,
Gila. Pati yung
that is an Anganwadi baby. Till other person class. ഒരു ദിവസം എത്ര മണിക്കൂർ? 1.5 മണിക്കൂറേ ഉള്ളൂ. എത്ര?
3 വർഷം.
വോയിസ് പ്രോബ്ലം തുടങ്ങിയിട്ട് ശബ്ദത്തിന് കുഴപ്പം തുടങ്ങിയിട്ട് 2 മാസം. എന്താണ് ശബ്ദത്തിന്? രാവിലെയാണോ വൈകിട്ടാണോ? തിങ്കളാഴ്ച വെള്ളിയാഴ്ച ശനിയാഴ്ച നമുക്ക് വ്യത്യാസമുണ്ടോ? നല്ലപോലെ ശ്വാസം എടുത്ത് ഒറ്റ ശ്വാസത്തിൽ ശ്വാസം കളയരുത്. 5 seconds. E. 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 So you can he has got a little bit of muscle tension. This one I is coming anteriorly. E. Okay. We can see that she has got a additional muscle tension. This one each side is trying to produce some retinode is coming anterior. But still you can see there is a little bit broad-based nodule on the right side and a small nodule on the left side. The broad-based nodule most probably looks like a polybodal nodule which Americans call bodule. And you can see that when patient is producing the sound, you will see a little bit of mucus that connecting each vocal cord. So that is called the string sign, which is probably the early sign of vocal nodule. On the right side, it's a little bit asymmetrical. That is the only thing. The right side is fairly little bit big, but it still looks like a polypodal nodule. From the history, she's an Anganwadi teacher. She has got voice abuse, breath support is very poor. The old suggests muscle tension is only with the early nodule. I think she should be definitely subjected to voice therapy. So, I think as far as we could see, there is definitely one of the DD, but I think the mucosal waves were there. In a cyst, the mucosal wave will not be there, but certainly that's a diagnosis that you have to consider in your mind because of the asymmetry and slight white color. But I think still, before taking her, probably she should be non-voiceable. We can try to concentrate once again. We'll look carefully for there is any presence of mucosal wave. The cyst shouldn't have much mucosal wave. Yeah, no. See, the thing is that sometimes, even after 6 weeks of voice therapy, you do the scoping, you will be there, but patient's voice will be much better.
6 months is back again.
Yes, he has got a definite, very unusual, not unusual, the